A very good afternoon to everyone. Welcome to today's session on PGS by Apollo Fertility. To speak on the topic today, we would like to welcome Dr. Anuranjita Pallavi. She has done her MBBS, MS in Obstetrics, and FRM. We welcome you, Doctor. You can now take over the session.
Thank you so much. So, a very good afternoon, all. I'm Dr. Anuranjita Pallavi, as she has already mentioned, consultant at Apollo Fertility, Navi Mumbai. So, today I'm going to talk on a very interesting topic about PGS and PGD, what we are doing at our center. And I would like to make you aware about these recent advancement which has taken place in the field of IVF. So, what do we mean by now? The question arises as what do we mean by a PGS and a PGD? What is the full form of this? So let's begin with the full form of what is PGS. PGS is nothing but it is pre-implantation genetic screening, and PGD is pre-implantation genetic diagnosis. Now, what do we mean by pre-implantation genetic screening? What are the patients and who are the patients who are included in this category, and when do we recommend PGS for a patient? So now pre-implantation genetic screening is done basically for those patients who are elderlies, like more than 35 years of age. Generally, we recommend PGS for women who are more than 38 years of age. And we do recommend it for patients who have recurrent pregnancy losses, or who have any known genetic disease in their family, or who have anyone who have a child who has been affected previously by any disease, any genetic disease. So so what do we mean by pre-implantation genetic screening? I mean, in pre-implantation genetic screening, the whole procedure is like an IVF. So what do we do is we again stimulate the patient, give them injections, take out all the eggs, and then we make embryos. And when the embryo reaches the blastocyst stage, we take a biopsy and we screen for the entire chromosome set of 46 chromosomes in that patient, just to be very sure that the embryo which we are putting in is genetically healthy. So that is when, especially in women who are more than 38 years of age. Now, what happens is with age, as we all know that women are always born with a certain number of eggs, which keep on declining with age, both qualitatively as well as quantitatively. So the number of the eggs, might be similar in a patient who's 32 years old or in a patient who is 38 years old. For example, I'm giving you an example. But then as the age advances, though the number remains the same, the quality declines. Now that is a normal physiological change, and that's why we always say that women have a biological clock which keeps on ticking, and we age, so the quality of eggs definitely declines. And in today's life, the habits we have, we do not maintain what kind of air we are breathing, what is the lifestyle we are following. These eggs, the aging of these eggs can happen at a much earlier age. And then what happens is, whenever there is a change in the quality of the eggs, the chances of women having abnormal embryos or the abnormal babies increase. Normally, this abnormality in the form of Down syndrome, which is known as trisomy 21, which is one of the common abnormalities which we see in aging women, because the quality of eggs decline with age. So Down syndrome, trisomy 13, trisomy 21, trisomy 18, these are the common genetic abnormalities which we see as the women age and the quality of the eggs decline. So if a woman who is 36, 37 years of age, she has gotten married late, she's planning for pregnancy. So it is much better that we screen the embryos and then we transfer them in her, so that she has a genetically normal child, and that relieves her of the mental trauma which she can have if she finds out later during pregnancy that she has an abnormal child. I'm not saying that there are no methods to diagnose this kind of abnormality when she's pregnant, because we have a lot of genetic testing which is done for these women when they are pregnant. For example, that we have NIPT, non-invasive prenatal testing, or amniocentesis, whatever. These are the methods which are available. But then going through a pre-implantation genetic screening helps you from all the mental trauma, and if you find out later during your pregnancy, for example, fifth month scan you do, and you find out that the pregnancy is not healthy. So that relieves you of all the mental trauma which a woman can go when she finds out later during pregnancy. In abroad, they do actually PGS screening for all the embryos. They believe that they should transfer only the genetically healthy embryos in the mother, whoever is undergoing treatment for an IVF, which is well, and which is fair enough, because we should give them a chance of having a genetically normal child when they are going, and then they're spending through to so much through an IVF treatment. So in our country, we generally recommend 35 years above, and mainly after 37 years to 37, 38 years, it should definitely be recommended in women, irrespective of any history of any abnormal child in their family, or if she has a previously abnormal child. Because as I told you, with age, the quality of the eggs which can lead which can lead to abnormal babies. So it's much better that we screen the embryos and then we implant into them. Now, coming to the PGD part, what do we do in PGD? What is PGD? Genetic pre-implantation genetic diagnosis. In pre-implantation genetic diagnosis, like in screening, as I mentioned, that you screen generally. It's a general chromosomal screening which we do. It is not directed towards a particular disease. It is just a screening, just to make sure that whatever we are transferring is a genetically healthy embryos. But what happens if a patient is diagnosed with a particular disease? For example, if the mother is a carrier of any genetic disease, for example, Duchenne's muscular dystrophy or any muscular dystrophy disease, and then she comes to you that she wants to have a healthy child who is not affected with a particular disease what she is a carrier of, for example, thalassemia, for example, muscular atrophies, for example, if she has a recurrent pregnancy loss, and if we find out that she has some genetic disease. So if we plan, if the couple has a known genetic disease which can be avoided, which they are looking for avoidance in their offsprings, then for them it is PGD, that is pre-implantation genetic diagnosis. So in pre-implantation genetic diagnosis, the probes, we have different probes, and now the technologies have expanded so much that we use next generation sequencing, where we initially it was fish technique. I would not want to confuse you and go into the embryological part of it, where we had fish technique initially, where we used to screen only the major embryos. Then came hybridization technique, and then now we have next generation sequencing, which where we can have specific probes for a particular disease, and then for that particular disease we can again, the procedure of IVF remains the same for any PGS or a PGD which we want to do. The procedure remains the same, that the patient has to undergo an IVF. We form the embryos, the biopsy of the embryos are taken, and the biopsied. And then we have to remember that normally we go ahead with a day 5 day 5 biopsy, is where we take out the cells from the trophectoderm or the outer cell mass, which eventually forms the placenta and not the baby. So we should not be worried about that we are taking out a cell which might form a baby's part later on and may get damaged if they undergo a biopsy. So that doesn't happen in PGS or PGD. We go till the blast stage, and blast, we take out the trophectodermal tissue for biopsy, and we do not touch the inner cell mass, where which forms the fetus later on. So whether it's PGS or PGD, the biopsy sample is sent, and in that biopsy sample we have specific, if we are looking, we have to mention it, whether we are going for a PGS or a PGD. If it is a PGD, they prepare certain that particular probe which is directed towards that particular disease. So once the biopsy sample is sent what happens is they send the tissues for examination for that particular disease, and if the embryo is having that disease, then we do not transfer those embryos. It comes as the report comes at whether the transfer of the embryo is free from the disease or not. So suppose if we get 10 embryos in the patient, and 10 embryos we find out only that one healthy embryo which is not having the disease can be transferred. So that embryo gets transferred, and then the offspring or the coming generation does not have the disease, and actually we can eliminate such diseases in such babies, and they can have a healthy and they can have a healthy child. And this is what we do in a PGT, where it is directed towards a particular disease. In PGS, I told you, it is a general screening, and PGS we also recommend in those patients who have a history of recurrent pregnancy loss. For example, they have had abortions. The recurrent pregnancy loss is typically in the first trimester pregnancy loss, where the heartbeat comes and goes, or something like that, 2 abortions, 3 abortions. In those cases where we and then we find out, we do a karyotyping and we find out the problem, and then we can go ahead with PGS and give them a healthy child. See, out of all the embryos, there might be a chance that all the embryos might be abnormal, or there might be a chance that at least 1 or 2 embryos are normal and transferable, where they can harbor a healthy child and which can continue till term, and they can have a healthy baby. So in those cases also we recommend PGS. Now we have some questions coming. Is it true, doctor, is it true that PGS damages the embryo? Definitely not. That is what I was explaining, that initially they used to do a day 3 biopsy, but nowadays they go for blast transfer. And in blast transfer, they remove a biopsy. There are 2 parts. In an embryo, if you see an inner cell mass and you see an outer cell mass. The inner cell mass forms the embryo, and the outer cell mass later on forms the placenta. So the tissue is taken from the placenta. So it definitely does not damages the embryo or the baby which you're going to have later on. Can be PGS test? Yes, definitely. Embryos have Down syndrome. Definitely, PGS is recommended. Actually, PGS, that is what I was telling you. As we age, the quality of the embryo declines. So in those patients, who are above 35 years of age, or who have had a previous history of a child, or maybe they have aborted a fetus who was, at a high risk of Down syndrome. So in those patients, we can go ahead with the PGS, screen all the embryos, and then we can transfer them, and we will be definitely very confident that definitely this child is definitely not going to be affected by Down syndrome. What other options are there for genetic testing if PGT is not right for me? See, normally we do a blood karyotyping. It is called as a blood karyotyping. That can be done, or if you have a history of recurrent pregnancy loss, then the karyotyping of the fetus can also be sent to know what is happening. Then, secondly, if everything comes out to be normal, and if you again want to go ahead with the genetic testing, if you get pregnant, then we have non-invasive prenatal testing, which is a blood test where we find out, free fetal DNA we take from the maternal sample, and we figure out whether the fetus is normal or not. And amniocentesis and becomes a more invasive test. It is not recommended until and unless you fall into that high risk category. Are there any risk associated with PGS and PGD, doctor? No, there are no risk associated, because the technology has advanced really a lot in the past 30 to 40 years, and there is definitely no risk, because we have skilled embryologists who do this. It is not that all the embryologists do it. It is the skilled embryologists who do it. So definitely there is no risk of damaging the embryos, or no risk to the embryo for sure. Can PGS end end my history of repeated miscarriages? Yes, if we do a carrier. See, recurrent miscarriages can be, because of a lot of reasons. That is one reason. Genetic chromosomal abnormalities, however, you will be really shocked to know that it accounts for 50% of first trimester abortions. So it falls for 50% of first trimester abortions. So definitely, if the karyotyping is, abnormal, PGS can definitely give you a healthy child, provided we get a healthy embryo, biopsied embryo. If it returns as healthy, we can, end that. But however, if the cause of recurrent pregnancy loss is different, for example, if there is any autoimmune disease, then the treatment is not PGS, and the treatment is definitely not PGS. So in that case, we have the other line of treatment. So PGS or PGD is only recommended in those patients of recurrent pregnancy loss who have genetic issues. So is prenatal testing necessary after PGS? No, you can avoid it because already we have done the screening and it is genetically healthy embryo. So prenatal testing is not necessary after PGS. What if I have no healthy embryos after testing? Now that's a big question. That if you do not have, there are, see, we need to analyze as to, a genesis. It's like a teamwork where a geneticist also comes into play, and we figure out as to what are your chances of having a normal child. Is it 1:4? Is it 1:2:4? Are there 50% chance, 75% chance? So if no healthy embryos are there, we find out where the problem is. We can again go ahead with the repeat cycle and figure it out. Or definitely, if there is a problem with the mother or with the problem with the egg, then we can go ahead with the donor egg and give you your healthy child. What if I have, yes, can PGS, PGD end my history of repeated miscarriages? That I have already answered. If it is because of genetic and the chromosomal abnormalities, yes, definitely. Doctor, what are the chances of having embryos with chromosomal abnormality? That is what I'm telling. That see, as you age, the risk of you having a genetically abnormal child increase, but it is not that everyone will have, everyone. But then basic screening test, even if you get pregnant, we do recommend it. But then PGD is recommended for a particular disease. If you have a particular, if the couple is suffering from a particular disease like a muscular dystrophy, we want to eliminate it from the cycle altogether and get a genetically healthy child, then it is definitely PGD. PGS is recommended if you have had recurrent pregnancy loss, or if you are more than 35 years of age, if you already had a affected child of any genetic, or if you have had an abortion because the baby was affected by any chromosomal abnormality. Yeah, so
That
does
was the
PGS
last
increase the
question we
chance
have,
of
Doctor.
success? Yeah, just one more query is there.
Yeah, sure.
Does PGS increase the chance of success? Yes, definitely, because you're very sure that you're transferring a healthy child. So definitely it does increase the success. Yes. So I'm done, I think, with all the questions.
Yes, Doctor, that was the last question that we had. Would you like to say anything before we conclude today's session, Doctor?
Yeah, I would like to say that please, I just took up this topic just to make, generally people aware that this technology is existing. It is not that, we should tell them that the PGS, recurrent pregnancy loss, also has a solution. Even genetic, the couples who are suffering from a particular genetic disease, we do have a solution where they can harbor their own genetic healthy child.
Right.
So, and both these technologies are available at Apollo, so you can definitely come, with any of the above mentioned issues you have, so that we can give you your healthy child.
Right. Thanks a lot, Doctor, on your informative session on PGS and PGD. We look forward to having you on more such sessions. Thanks a lot for your time, Doctor. Thank
Thank you
you.
so much. Thank you. It was lovely
Thank
talking
you.
to you. Thank you.
Thank you, Doctor.